It had.
Right, but still, he was saying that there is a plate is little bit bent. So you need to have a little plate will be longer.
One more question, not regarding infection, but when you are routinely doing this for tumors, so when you are putting a plate, there is a long plate with length which is without screw. So do unicortical screw, if we put there in a locking mode, whether they prevent the stress riser at the plate holes? No, no, I'm asking in between. There is a whole length of plate which is not supported by bone. Okay. And you are doing fibula. Am I right? So fibula is a shorter bone completely. And you are not fixing the fibula at every level. So whether to avoid bending of plate, is it okay if we put a unicortical screws? Is there any article or something on that? No, no, I'm asking about plate, bending or breaking of the plate, because the span is big enough. So, like we use for tomofix, they use a unicortical screws, okay, to avoid that plate. Yeah. So something like that can be used.
You want to block the holes.
Absolutely.
Yes,
So, is it biomechanically stable
I have
compared to
not
this?
done that, sir. We have not done that.
No, I mean anyone knows any article or something like that, because there are very high chances of failure of plate. I'm not asking about the fibula, but plate.
In short, the summary was good planning on day one, vancospacer induced masculate membrane, and then use of a vascular fibula. No external fixator at any point of time during the treatment. So this was the strategy followed in this case, and we follow this strategy in most of our cases. Thank you so much.
आगे Thank you. Now I would.
Hello, hello. I'm audible. Hello. Yeah. So good afternoon, all of you. Presenting my case, being an orthopedic arthroscopy surgeon, I got a call from my intern saying that there is a 35-year-old male who had a knee pain and MRI was suggestive of some medial meniscus pathology, and patient was scoped by me, uh, and intraoperatively or scopically there was not much of finding. Means there was no any meniscus tear, nothing, no any instability, but the patient was still having pain, and with this, video ला play करा yeah, this. Okay, so with this, clinically, I have not examined the patient before putting the scope. But with this, the patient came to my OPD. The patient is definitely having lurch. Okay, there is a shortening, and put again. So to start with the patient, digging the actual history, he had a femur fracture, which is about 1 year back, and he was operated with probably a open reduction and internal fixation seen on the sequential X-ray. So this was his X-ray to begin with. Sorry. So this was his X-ray to begin with. It was like mid-shaft segmental, not segmental, spiral oblique fracture with a fragment. So he was nailed with intramedullary nailing. So any comment about fixation? This was done on day one. It was operated by a primary surgeon, the other surgeon. So maybe because of difficulty of reduction or difficulty of this thing, he might have opened it and put the circulage wire and nailed it.
Thicker nail could have been used. One thing.
Right.
Second thing, the femur looks straight on lateral view. The natural bow has been lost.
Yes. Yes.
And
Exactly.
maybe he could have used one more circlage. The circlage is at the lower end of that fragment. So I would have gone for a thicker nail.
Right.
That could have probably restored his
Anything? Any
curvature.
comment about the bow of the anterolateral bow of
Yes,
the nail bow was
bow has been lost.
lost? Yes.
Did he use the opposite side nail?
Yeah. So
Okay.
that was the
Opposite side.
the opposite side nail, and the anterolateral bow was not matched, was correctly pointed out by Dr. Santapure sir.
Distal screw only one. He has put only one screw.
Yeah. So patient, which correctly pointed out, the anterolateral bow was lost. At 6 month post-op, patient was consistently having pain, and you can consistently at pain at fracture site and even at the knee side. So even at the knee, this was at 9 months. Yeah.
Which type of nail it is?
It's a recon nail.
It is a universal proximal femur nail because we are seeing some holes in the up above also.
So this was done by the other surgeon.
But,
Which company nail or which company nail? But this probably looks like a universal femoral nail.
But then you said it was for the opposite leg, opposite side.
No. For the same limb. For the same limb, he was operated. For the same limb, for the same side, he had a femur fracture, and then the same knee. For the same side, he has a knee pain, and that's why the scopy was
But
done.
why the nail is straight? The nail should have it should be anatomical.
That's why the bow of the nail was not matched. While putting the nail, the bow of the nail was not matched.
Not matching, or it is
How do we
supplied by
match
the. How can you match bow of the nail with the bow of the femur?
No, the anterolateral bow, the nail usually.
You are doing locking from lateral to middle. It ultimately says that the bow is maintained. No, we are
Yeah.
not doing locking from anterior to posterior or like that. He is doing locking from lateral to middle. So ultimately, bow is maintained because any.
Yeah. No, but this. Okay.
It could be
Yeah. Yeah.
it could be the Cyrus nail, which he must have used the opposite side nail, right left. It comes in the different size, right and left.
So that we don't know. In drop, what was
reason
done?
for mismatch of the bow.
So in drop, what was done, that was not known. So this was at 9 month post-op, and implant removal was done by primary surgeon. And with this scanogram, with this picture, he presented to me. So now the patient is having shortening, one, varus deformity at fracture site, femur shortening, hypertrophic non-union probably, and query infection.
But why was the nail removed when he was not sure about the union? There
So
was no.
the primary surgeon took a decision of removing the nail early.
Then probably it was removed for infection.
Yeah. So at this stage, he presented to me whether this was removed because of infection or because of consistent pain, but there was no discharging sinus, nothing. But the only complaint was consistent pain, and he was not able to weight bear even after 1 year of nailing.
So now we have to go back, go inside, explore everything, remove both the cavities, and if it looks clean, it can be refixed again with a nail and bone graft.
Right. No, we can see, as of now, we have to put the bone graft, as sir said. The plan was yes, to have the additional the stability and a proper fixation. with
Regarding that deformity, as it is a non-Indian on table with fracture, we can correct that with manually. After putting a nail, we can correct that if it is correctable.
Yes. So what suggested, the blood investigation was within normal limit. There was no any signs of infection. CRP and ESR was normal. And what was the pre-operative planning? So we planned in lateral position, rimming, obviously a bone graft, and as sir suggested, with a larger diameter nail. So this was, so this, sorry, the one slide is missing. This was the post of X-ray as sir suggested. We put a larger diameter nail and we put iliac crest stud graft, which was fixed with 3.5 cortical screw at the fracture site. So it is not a cancellous graft. It was a tricortical with corticocancellous graft. So
He used that strut as a plate.
But do you
It's a
recommend?
biological
Do you
plate.
do you recommend in hypertopic non-Indian bone graft and putting a screw at the fracture site?
It is not recommended, but once he has decided to use a bone graft, it was a large, I suppose it was a large
larger
chunk of
diameter
bone.
nail, yeah.
And rather than keeping it floating, the idea was to fix it to the bone.
What is the
Right.
use? What is the aim behind putting a strut graft at the fracture site?
So it was a corticocancellous graft to have the additional, like while putting the extra plate, unicortical plate, rather than putting an extra unicortical plate, I put a corticocancellous graft with the screw.
Was there any suspicion of infection?
No intra suspicion of any infection. So this was his function
Excellent.
video. So need to know the proper history before doing any case, proper preoperative planning, check your implant intraoperatively and avoid improper fixation and early removal of implant. Thank you. Now next is the presenter is from Dr. Lingayat sir's team, Dr. Abdullah sir.
Good afternoon, everyone. Myself,
To the referral. Yes, sir.
Aman, na? Aman. I would like to call Dr. Aman to present his case.
Good afternoon, all of you. Good afternoon, all of you. Myself, Dr. Aman, junior resident from GMCH Aurangabad, under the guidance of Dr. Lingayat sir, head of department GMCH Aurangabad. I am presenting a case, 85-year-old male with history of self-fall at home, 10 months back, for which he was consulted at nearby hospital and he was diagnosed with transcervical neck of femur fracture and he was admitted in the hospital and posted for hemiarthroplasty. But unfortunately, uh, outcome of that operation was this girdle stone. Uh, it was atherogenic intra shaft femur fracture. Uh, Respected dignitaries, what could be the reason for this atherogenic fracture?
The fracture ends it looks to be hitched into each other. Probably it was a subcapital fracture. Before he could disengage the fracture, he tried to rotate it, internally rotate it. Probably that could have led to the spiral fracture of the proximal femur. What I would do, I cut the neck, okay, at a desired length and then derotate it. Okay. Yes, probably the fracture ends were entangled, and then
See, I guess the film is flipped on the right side, but in any case, if at all you see, probably while inserting the stem, the processes was put into a lot of virus, and hammering it has probably caused this fracture. This is one of the most potential cause. Secondly, the wiring has been done in an odd fashion. If at all you see, there is an overriding of the fragments of around 2 centimeters. So the neck which was initially cut for the calcar to sit, or the calcar which was supposed to be made there, so the GT has come down with the lateral fragment which was supposed to be on the higher side, maybe around 2 centimeters of shortening has been there because of the wires over there. And I guess it is the virus placement and hammering. That can happen to anyone, but probably I guess that could have been the reason if at all we cannot make out any fracture on day one.
Thank you, sir. Then the patient was kept for 3 months on skeletal traction, and this is the X-ray. The patient came to our OPD 3 months later, and this is the fresh X-ray at our OPD. What could have been the treatment options for this patient at this age and after 3 months of this surgery? Respected dignitaries.
Right. Uh, One, if possible, if the patient was medically fit after that fracture has happened, obviously the long stem processes would be required because the proximal metaphyseal stem will not work. So we need to calculate the diameter at the lowermost point of the fracture site, go to lengths above that, and that's the length of long stem. So that stem obviously would not be available on day one, but you can explain to the relatives and do the surgery in the same admission would have been ideal. Maybe a week apart also is fine. But by now, it's 3 months. The soft tissues have contracted. The challenges have increased, and probably the canal has now become more narrow proximally. So challenges are going to be soft tissue uh, release, exposure, getting the length. Maybe think of an adductor retinotomy as well. Pull it out to length, see on table whatever we get, and then remove those cerclage wires, open the canal so you get a good uh, space to ream, and then use the long stem. Whether cemented or uncemented, that's up to the surgeon.
Yes, sir. As the patients were willing for operation, because the patient was bedridden since 3 months, they were asking for early mobilization. So we have planned for long stem total hip replacement and uncemented total hip replacement. And a preoperative assessment has been done. ESR and CRP and routine blood workup was done, and ultrasonography of hip was done. There was no any collection, and then we have planned for uh, uncemented total hip replacement, and we have taken the traction X-ray also. We have done the posterolateral incision, and we have removed the callus formation which was there at the fracture site and removed the encerclage wires. And then we have reduced the fracture and did uh, encerclage at 3 sides. And we have prepared the canal serial rimming by 8 and 9 mm. And then we have inserted the 9 mm and 23 centimeter prosthesis, and we have inserted a distal locking for additional stability. And patient was mobilized on day 3. Patient was taught static quadriceps and ankle exercises, and bedside knee range of movements have been started, and patient was made to walk with the help of walker from day 3 onwards. And this is the follow-up X-ray after 6 months. Patient is doing all his activities of daily living and walking without support, and is also able to climb upstairs. Uh, this was 6 months post-op. Patient is walking. There is no limping, and limb length discrepancy was also not there. And modified Harris score is 95, post-op 95. Yes. Thank you, sir.
Thank you.
Lunch is being served, so we'll take a one more case. Dr. Ahmed.
Good afternoon, everyone. So, good afternoon, everyone. So, my case for today is closed total talar dislocation, which was presented in our casualty in GMCH Aurangabad. So, it is a very rare case, a closed total talar dislocation, which means that talus has all three joints that talus makes with the navicular, with the calcaneum, and its ankle joint. All three joints are dislocated uh, at the same time. So it's a very rare case. So a 42-year-old male patient who received a severe impact on his left lower limb because of a road traffic accident was brought to our emergency on tertiary level trauma center. On arrival, he was hemodynamically stable, conscious oriented. So we sent him for radiological examination. So here's the picture what we saw on his X-ray, AP lateral, and here's a 3D CT. So we can see that talus has medially rotated in its space, dislocating ankle and subtalar joint, and also we can see here that talonavicular joint has also been dislocated. So what would be the management? So continue forward. Uh, Patient also had a D12 wedge compression fracture, but his neurology was normal. So here's the options for the management. So close reduction, direct by traction and plantar flexion, and by applying plantar flexion and traction, we can closely reduce the fracture, or use a K-wire as joystick to reduce the fracture, or open reduction. But the dilemma with the open reduction is that we have all due to its total dislocation of the talus, there is already compromised blood supply to the talus. So by open reduction, we are already compromising the blood supply. We are further compromising the blood supply of the talus. So here's we took the patient in our OT. So patient was very lucky. We were able to reduce the fracture by simple joysticking the talus, and we applied a external fixator, ankle spanning external fixator. So here's the X-ray on after 3 months. We removed the external fixator, and here's our X-ray, AP lateral, showing no avian changes on the talus. So here's an MRI. We have performed an MRI after 3 months after removing the external fixator, which showed no avian changes. So we started the patient on weight bearing, and he has already he got his dorsiflexion was quite restricted, but and plantar flexion was around 20 degrees. So thank you.
So with this, I conclude the sessions, meet the masters, and lunch is being served. You can have a lunch and then come back and start our uh, next session.
कोणाचं आहे?
Shoot.